So we should tailor evidence-based lipid management strategy, integrating global guidelines like LAI, ADA, and American Heart Association guidelines. Should be discontinued. We should add composite drugs. We should add combination drugs to halt these SCBD events to occur. And use personalized intensity therapy, focus on early intervention, combination therapy, strict LDL and triglyceride targets, and achieve the optimal lipid control as suggested by different guidelines. And out of all the lipids, this is the LDL cholesterol, which is the most important cholesterol we should target, because this is the most atherogenic and it produces most of the atherosclerotic cardiovascular disease like myocardial infarction, heart failure. So we should target this LDL cholesterol, and it has been substantiated by different studies. And these are the types of lipid disorders. So first, the primary or genetic disorders like familial hypercholesterolemia, familial combined hyperlipidemia, familial chylomicronemia, and secondary, most of the time it is because of diabetes, obesity, hypothyroidism, CKD, CLD. These are all modifiable risk factors. So this is the secondary cause of lipid disorders. And classification, this is the classification: hypercholesterolemia, hypertriglyceridemia, mixed dyslipidemia, hypo-alpha lipoproteinemia, and there is another classification of WHO predictions classification, type 4 to type 1 to type 4. And what is the prevalence of these lipid disorders in India? This ICMR India study have opened the eyes of Indians. You see the prevalence of hypertriglyceridemia in our country. These red bars are more than 25% prevalence of hypercholesterolemia. And high LDL cholesterol around all part of the country, most often it is Himachal, UP and Rajasthan, where the prevalence is more than 20%. And this hypercholesterolemia, again, Rajasthan, UP, Uttarakhand and our state is in the range of 20 to 24% prevalence. It is very high, necessitating earlier interventions. And low HDL cholesterol, this is a pan-Indian phenomenon. You see, all the states of our country are having low HDL cholesterol, which is contributing equally to the development of SCBD disorders. So what is the screening and targets? So our own lipid association guidelines, they have been doing it for last 10 years. They have recommended the risk assessment, primary lipid targets and target levels. We should learn how to achieve a target level of LDL cholesterol less than 50, 70 or less than 30. This flow chart shows everything about lipid association of India guidelines. They have risk factors, major SCBD risk factors like age more than 45 years, female more than 55 years, current cigarette smoking, and high blood pressure, low HDL cholesterol. These are the high risk factors, high risk features are there, risk modifiers are there. We should see these risk modifiers like lipoprotein levels, impaired fasting glucose, HCRP, plasma triglyceride, rheumatoid arthritis, psoriasis, spondyloarthritis. So they have categorized, this is the additional factor which has been incorporated as cited by the ADA and AHA. These are the risk groups: low risk group, moderate risk group, high risk group, very high risk group, and extreme risk group. So these are the group which are having multi-organ dysfunction, multi-comorbidities like diabetes, hypertension, old age, and they will be having a lipid target of less than 30. So this is new about LAI guidelines. And what are the targets? Low risk less than 100, moderate risk less than 100, high risk group it is around 70, and very high risk group is around 50. This comes from diabetes with hypertension with coronary disease. Extreme risk group along with familial hypercholesterolemia or CKD, CLD or coronary artery calcification more than 100, more than 300. Here the target is less than 30, or in extreme category C, it may be up to the lowest of 10 to 15. And this is the flow chart depicting all those features. And ADA, they have the similar guidelines. All adults more than 40 years with diabetes, their target is LDL cholesterol less than 70, LDL cholesterol less than 55 in very high risk patients with diabetes plus established SCBD. And monitoring is equally important. AHA or American College of Cardiology, again, they have the adults more than 20 years. Here we have to fasting or non-fasting lipid profile, more frequent in those with risk factors. And they use the SCBD risk factor, risk calculator of 10-year risk. Whereas our own guidelines, it composes the lifetime risk. This is the difference. And their targets is LDL cholesterol and non-HDL cholesterol. So these are the major classes of lipid drugs available in our armamentarium. Statins, ezetimibe, PCSK9 inhibitors, they are the new class of novel drugs which target LDL cholesterol to the lowest level. And these are the bile acid sequestrants. And TG lowering drugs like fibrates, omega-3 fatty acids, niacin, and bempedoic acid, saroglitazar, statin. These are the combination therapy available. Statin, ezetimibe, statin, PCSK9 inhibitor. And these are the treatment goal. We have to adopt multiple combinations. And this inclisiran, this is siRNA inhibiting PCSK9 synthesis, dosed only twice a year. This is having high LDL cholesterol lowering capacity. And these are the percentage of LDL reduction. We must know that moderate intensity statin around 30%, high intensity statin around 50%, high intensity statin plus ezetimibe around 65%, PCSK9 inhibitor around 60%, PCSK9 inhibitor with HIS more than 75%, and PCSK9 plus HIS plus ezetimibe, this is 85%. This should be used in all cases of recurrent acute coronary syndrome or high SCBD with high risk category, very high risk category, category C. These are the drugs, high intensity, moderate intensity, low intensity, we all know. And what is the recommendations? Lie recommendation, when to start therapy, first line therapy is always statin. If LDL cholesterol is not controlled, you can add ezetimibe or bempedoic acid. If still not controlled, you can go for PCSK9 inhibitor. This is a lie recommendation, and special consideration should be adults starting from 20 years or college entry, because we should screen the youngsters, because metabolic syndrome and obesity is very common in the college going students. And if you will screen earlier, the complete lipid profile with the ApoB component, LDL cholesterol, non-HDL cholesterol, we can have a risk calculator, we can have a prediction of future coronary events. And AHA, again, their recommendation is that high intensity statin, if SCBD is there and LDL cholesterol is more than 190, or diabetes, moderate intensity statin for diabetes age between 40 to 75 years. And add-on therapies, ezetimibe, PCSK9 inhibitors, if LDL cholesterol is not controlled after initial statin. ADA recommendation, again same. These are the same recommendation by both AHA and ADA. So some clinical scenarios I will discuss. This is a case, 52-year-old male with diabetes mellitus, BMI 29, lipid profile showing LDL cholesterol of 138, HDL cholesterol 34, and TG is 245. So this is a very common scenario in our setup. You see all the guidelines have shown that ADA, AHA, LAI, they have shown that you have to go for lifestyle modification first, and you have to add high intensity statins, because this is a very high risk group, diabetes with SCBD risk. So these patients should be advised HIS, rosuvastatin 40 mg, lifestyle and diet. If still not controlled, then you add ezetimibe or PCSK9 inhibitors. You have to take care of TG if it is more than 500. If it is less than 500, we need to screen the patient for familial hypercholesterolemia. Case 2, this is a 38-year-old male, history of hypothyroidism, recurrent abdominal pain, and lipid profile is 8, TG is 865 mg per deciliter. This is a common scenario in our state, in our country. So here, this is severe hypertriglyceridemia, and all guidelines, they have recommended to use, if TG is more than 500, use fibrates or omega-3 fatty acid, and address the secondary causes. Lie strongly emphasize on TG control in Indians due to associated SCBD. So these patients should be started with statins plus fenofibrate plus omega-3 fatty acids, seeing the scenario in our country with a earlier onset SCBD events. This is a recommendation by Lie. It is available in net. Case 3, this is a 60-year-old male, recent entry-level MI, Lipid profile LDL cholesterol is 78 on moderate statin. Moderate dose statin. This is the most common scenario in our state. After PCI, patient is prescribed medium intensity statin, which leads to secondary attacks or coronary plaque regeneration, restroke, which is very common. So you have to target the post-AMI secondary prevention, and all guidelines have recommended for secondary prevention you have to add high intensity statin plus ezetimibe so that LDL cholesterol will be less than 55 milligram deciliter and patient should not have a secondary attack or secondary coronary stenosis. This is the flow chart of LAI where everything has been depicted. And another case 4, 64, 60-year male with hypertension with heart failure. This is a common scenario in our country, whether to give statin or not in a patients of hypertension, diabetes with a heart failure. You see, all the guidelines have significantly said that no significant benefit of statins in a patients of heart failure with reduced ejection fraction if mortality is between 3 to 5 years. And AHA also reasonable to use statins in heart failure with reduced ejection fraction if life expectancy is 3 to 5 years. So very sick patients with multiple comorbidities, you should be very cautious while using statins. And case 5, this is the last case, patient with CKD, whether to give statin or not. This is a very controversial topic. And here LDL is 190, HDL is 35, TG is high. So this AHA and ACC, CKD not on maintenance hemodialysis. You can start on statin and ezetimibe. So stage 3, stage 4 patients who are not on hemodialysis, we can give statin or combination. This SHARP trial, Aurora trial and 40 trial, no benefit of statins in maintenance hemodialysis patients. So if the patient is having CKD, stage 1 to stage 4, we can use statins. But if the patient is on hemodialysis, there is no use of using statins, rather it will increase the toxicity. And LAI is going to recommend regarding the CKD, use of statins in the CKD in next 3 to 4 months. So to conclude, a healthy lifestyle should be emphasized across the course of life. All guidelines should advocate a lower LDL cholesterol. The lowest is the best. If zero, nothing happens. So it is better to go to the lowest. And lipoprotein A levels may help identify the inherited risk of SCVD. This is very common in youngsters with obesity. And non-LDL cholesterol is accurate predictor of CV risk, particularly for those on statin therapy. So there are no adverse effect of very low LDL cholesterol or zero LDL cholesterol. So why not? We should go for a lowest LDL cholesterol target in all patients with SCVD. So thank you. I will finish by starting this quote. Statins are like strict teachers like Dalai sir. He always inspires and also he also takes every matter seriously. So they will keep always the LDL levels in check and prevent heart attacks. Thank you. And lastly, last slide. So we are going to organize the APCON state chapter in our MKC Medical College in the month of November. And with the chairmanship of Dalai sir, our scientific chairman Singh sir, and our co-chairman scientific Sarita ma'am, I invite you all to attend in large numbers, taste the food of Barampur. We'll be hosting a large number of food delicious. Along with that, use the property of Mayfair Gopalpur. There are another resort, Pramod Resorts, and another Regal Palm Resorts is also coming up. So I'll request everyone to block the dates. Thank you.
Thank you, Dr. Sahu, for your nice and elaborative talk.
Thank you, sir. Please join me welcoming Dr. Dinabandhu Sahu, Senior Consultant, SRM MCH, DHH Bhavani Patna, as he takes us through the topic Diabetes and its Ramifications. Sir, please approach the stage.
So our next speaker is, who does not need the introductions, who is the man of the show of today's program, who is the organizing secretary of today's midterm CME Odisha State Chapter, Dr. Dinabandhu Sahu, who is now working as Senior Consultant, SRM MCS, DHS Bhavani Patna, and fellow in cancer chemotherapy and different, got fellowship in different society. So I invite Dr. Sahu to start his talk. Over to you, sir.
Thank you, chairpersons. So it's a great pleasure to be on the dais as a speaker too. So thank you all the delegates, those who are still with us after the post lunch. So my topic is diabetes and its ramification. So the goal of my talk or the talk plan will center on a little bit introduction on diabetes, its prevalence in India as well as in the world, its diagnosis, how to detect, how to diagnose and how to manage, and what are the complications, acute complications, chronic complications, and how to prevent. Slides. Nice. Alga topic. Okay. So this will be my talk plan. To give a little bit introduction about the diabetes. This is the widely prevalent disease, the non-communicable disease. As per the statistics in 2024, there are 589 million people worldwide. They are suffering from diabetes, which will be around 853 million by 2050. And out of 5, each 4 persons they are having diabetes throughout the world. So in India, as per the statistics, around 100 million people, as per 2024 statistics, 89.8 million people they suffer from diabetes. By end of 2050, the number may reach to 156 millions. The matter of concern is the younger people are detected early diabetic with developing complications. So before going to its ramification, so to say the consequences and complications, we must look into the definition of diabetes. That is, it is a metabolic cum vascular syndrome, is a state of chronic hyperglycemia because of defects in insulin secretion, action, or both, affecting small blood vessels, that is what is called as microangiopathy, and large blood vessels, that is macroangiopathy. So there are 3 broader categories of diabetes, that is type 1, type 2 diabetes, and gestational diabetes. As all of us know regarding all these 3 major types. So far as the diagnosis is concerned, if the HbA1c and fasting plasma glucose and random blood sugar is taken into account for proper diagnosis, HbA1c should be more than or equal to 6.5%. Fasting should be more than or equal to 126 milligram per deciliter. Similarly, the OGTT or random blood sugar should be more than 200 with signs of diabetes. So this is the diagnostic criteria. And coming to the complication of diabetes, why complication matters? In fact, diabetes complications, they lead to morbidity and mortality. They reduce quality of life, leading to complications like blindness, kidney failure, and amputations. There is increased risk of cardiovascular death 2 to 4 times more in comparison to the normal group of patients. Then in fact, it drives healthcare costs significantly. So the mechanism behind the pathogenesis and different complications, that is the added effect of inflammation, oxidative stress, insulin resistance, hyperglycemia, all of them escalates the risk of diabetes-related complications. So the inflammation, the lifelong, diabetes is a chronic inflammatory process where there is chronic low-grade inflammation. There occurs release of inflammatory cytokines like interleukin-6, TNF-alpha, which leads to endothelial cell injury, which leads to ultimately the impaired vasodilation because of decreased nitric oxide availability. So what are the risk factors? They actually accelerate these complications. They are hypertension, dyslipidemia, smoking, obesity, and genetic predisposition, obviously the family history too. Regarding the complications, there are different complications. So far, the acute and chronic complications are concerned. The acute complications are diabetic ketoacidosis. Another one is HHS or hyperosmol or hyperglycemic state, and another one is hypoglycemia. Chronic state leads to complications like affecting the microvascular and macrovascular complications. That is, microvascular complications are diabetic retinopathy, diabetic nephropathy, diabetic neuropathy. And the macrovascular complications are affecting the bigger vessels, and those are coronary artery disease, cerebrovascular disease, peripheral arterial disease. So this is the picture. Almost all the organs are affected out of complications. Earlier we used to listen that if you do not know syphilis, then you do not know anything about medicine. But nowadays, if you do not know about diabetes, perhaps you know nothing, and the diabetes affects all the system of our body. Coming to acute complications, the life-threatening diabetes complication is the diabetic ketoacidosis, which is caused by insulin deficiency. There occurs increased blood glucose and ketones. Fat breakdown into acidic ketones happens, and the patient may develop metabolic acidosis with Kusumal breathing. The symptoms are like thirst, severe thirst, decrease in urination, vomiting, pain, etc. Triggered by infection, missed insulin dose are the root cause. The treatments are with IV fluids, insulin, and potassium correction, the electrolyte replacements. Similarly, the hyperosmolar hyperglycemic state, that is HHS, that is mostly seen in the elderly age group. There occurs severe hypoglycemia without ketoacidosis, usually in type 2 diabetic patients. Their patient may develop marked dehydration and high osmolarity. Patient may have altered consciousness and may develop seizures. The blood sugar is usually more than 600 milligram deciliter, pH is more than 7.3, and there are complications like increased risk of clotting. Patient may develop renal shutdown with kidney failure. The treatment is like that, decay with IV fluids, insulin, and potassium correction. So coming to chronic complications, one of the most chronic complications is diabetic retinopathy. This is a microvascular damage to retinal vessels, leading cause of adult blindness. The disease starts with non-proliferative phase and ultimately ends in proliferative stages. The symptoms are patient develop blurred vision. There may be flutters or dark spots. There occurs macular edema, which causes vision loss. The risk factors are poor glucose control and hypertension. Treatment is a laser and injection with anti-VEGF and surgery. So this is the pictorial depiction. You can see the neovascularization, microaneurysms, exudates are there in the left side fundoscopy diagram. So another complication, the most important one, is diabetic nephropathy. So which is the diabetes being the leading cause of the majority of the cases of chronic kidney diseases. They suffer from diabetic nephropathy. Patient develop proteinuria and declining renal function. There occurs the glomerular basement membrane thickening. If the patient is having hypertension, then the effect is added up. The hypertension worsens kidney damage. Patient progress to end-stage renal disease in the due course of time. Here, RAS plays key pathogenic role and managed with glucose and BP control. And many of the times, patient may need hemodialysis. Similarly, the coronary artery disease, this is one of the major cause of death. Those who are having diabetes, the risk is 2 to 4-fold. Atherosclerotic plaque that blocks coronary arteries. It causes myocardial ischemia and infarction. Symptoms, patient usually have chest pain, shortness of breath. Sometimes painless presentation is there with the patient, those who are diabetic because of autonomic involvement. The disease is diagnosed by ECG, angiography, and stress test, treated by lifestyle, medicines, PCI, and bypass surgery. It is the leading cause of heart-related mortality. So another complication of that is cerebrovascular disease, which is widely discussed before in the prior session. The disorder reducing brain supply, brain blood supply because of the macroangiopathy. It causes stroke, TIA, or aneurysm. Symptoms are hemiplegia, confusion, speech difficulty. The risk factors are hypertension, diabetes, and atherosclerosis. Prevent with control of risk factors. Immediate treatment is crucial to reduce the damage. It includes ischemic and hemorrhagic stroke. Similarly, the diabetic neuropathy, nerve damage is in sensory, motor, and autonomic. All three are involved. It may lead to development of foot ulcer. With the involvement of autonomic neuropathy, there occurs orthostatic hypotension, even the loss of libido. They may be the hidden complaint which should be explored while interacting with the patient. Peripheral arterial disease, there is because of the narrowing of peripheral arteries, reduces blood flow to legs, feet, causes leg pain during walking. Risk factors are the smoking, diabetes, hypertension. Diagnosed by ABI, ankle brachial index. It can cause ulcers and limb ischemia, treated with lifestyle and medications. You can see how the arteriomatous plaque, they are narrowing the lumen of the vessels. So coming to diabetic foot ulcers, it's a combination of neuropathy, peripheral arterial disease, and infection. There is always risk of cellulitis. Patient may develop osteomyelitis in long run. So these are the few changes, skin changes, calluses, foot ulcers, poor circulation. Even patient has to lose the limb. That is what is called the amputation. The second most cause of amputation besides road accident. Foot care protocols, patients should be conscious how to take care of the foot. Daily inspection, hygiene, proper footwear, and podiatric care should be taken. Even with slightest infection, patient has to be treated with proper antibiotics so that secondary infection may not complicate. Chronic macrovascular complications, these are cardiovascular disease and diabetes. There is 2 to 4 higher risk, already discussed. Even patient may have silent myocardial infarction. This is the #1 cause of death in diabetes associated with poor long-term outcomes. Myocardial infarction and heart failure, MI risk doubled in diabetics. Heart failure more common, both reduced ejection fraction and preserved ejection fraction. Silent MI common due to neuropathy. Atherosclerosis in diabetes, accelerated plaque formation, mechanisms like dyslipidemia, endothelial dysfunction, inflammation, affects coronary, cerebral, and peripheral arteries. Lipid abnormalities in diabetes already discussed. So there occurs increased triglycerides, the HDL is reduced. Also there is decrease in small dense LDL, strongly atherogenic, and statins are the key drugs for therapy. So other complications, diabetic infections like like tuberculosis, fungal infection, out of candidiasis and mucormycosis are also widely prevalent in diabetic group of patients, which we have experienced in COVID-19. So these are the few skin complications: bacterial infections, fungal infections, itching, diabetic dermopathy. Patient may develop allergic reactions, blisters, eruptive xanthomatosis, digital sclerosis, acanthosis nigricans, which is the hallmark of diabetic insulin resistance. So the diabetic blisters, they occur rarely in individuals with diabetes, can occur on the backs of the fingers, hands, toes, feet. Eruptive xanthomatosis, this is a condition caused by diabetes that is out of control, consists of farm, yellow, pea-like enlargements in the skin. The disorder usually occurs in the young men with type 1 diabetes. So here is another, that is digital sclerosis and disseminated granuloma annuli. This is also seen in few group of patients. So another is acanthosis nigricans, that is the hallmark of insulin resistance. In the neck area, armpit area, that is dark pigmentation of the skin. Regarding gastroparesis in diabetes, the set of patients, many of them develop gastric upset with heartburn, nausea, vomiting and of undigested food. Patient may develop weight loss with abdominal bloating, lack of appetite, gastroesophageal reflux, etc. These are the signs and symptoms. So a number of patients, they who develop cognitive decline or dementia, those who are suffering from chronic hyperglycemia, there is increased risk of Alzheimer's and vascular dementia. The mechanism is vascular injury, insulin resistance in brain, more common in elderly diabetics. They impact diabetic self-care and medication adherence is crucial in preventing this state. Special population like pregnant mothers, elderly age group because of the risk of hypoglycemia, and children and adults, and they take special precautionary measures and special counseling. So these are the wide variants of complications so far as the microangiopathy and macroangiopathy is concerned. Coming to preventive strategies, the tight glycemic control is crucial. Patient must have the normal blood pressure, controlled blood pressure, lipid management should be absolute. And the lifestyle related to diet, exercise, weight reduction should be advised to. Smoking should be avoided. And new therapy, newer drugs like SGLT2 inhibitors, GLP-1 receptor antagonists are prescribed to prevent the complications. So screening and early detection, the patient must do some investigations preventive to prevent the complications. So that is annual eye, kidney, food screening, cardiovascular risk assessment, use of simple algorithms and checklist so that patient can understand. Early detection saves cost and prevent disability. So these are the lifestyle habits: regular physical activity, optimum sleep, minimum 7 hours per night, and a balanced diet. So the blood sugar should be in target range. And this is the chart how we should stick to different investigations and advise the patients yearly or monthly. The investigations should be done regularly to assess any complications. So key takeaways are: the diabetes complications drive morbidity, mortality, and cost. Acute complications are DKA, HHS, hypoglycemia. Chronic complications are microvascular, macrovascular. Prevention and early detection are crucial. Evidence-based therapies, they improve outcomes, so should be adopted. So these are the key takeaways. The diabetes complications are largely preventable with proper management. Early detection is crucial for all complications. Comprehensive care addresses multiple risk factors. Patient education and self-management are essential. Regular screening can prevent irreversible damage. Thank you.
Thank you,
for
sir.
patient listening.
Thank you for your excellent talks. And you touched the every corner of diabetes, starting from prevalence to preventions. Thank you, sir. Whole chapter of diabetes, as said by Dalai, sir. Thank you, sir. Thank you.
Thank you, sir.
So we'll proceed for the next
Sir,
topic.
Before that, sir, we all have heard that you are very good at mimicking. So, on behalf of the house, I would request you to please perform a brief act.
Okay, thank you, but we are getting late. Anyway, to keep the request of the house, I will perform few of my mimicries, sir.
Let's have it during the valedictory session.
Okay.
We should not mix valediction. Valediction. You don't have to introduce me. I will. No slides. No slides, Rahul. Dinobandhu wanted me to talk on insulin. से मते फोन कला कहला सर भवानी पटना रे बहुत कम लोग को इंसुलिन लेखुछंती आपन टिके इंसुलिन विषय रे कहंतु सो आई हैव सीन and they told me that they are from Burla. Then why are you here? What is that term called? DRP. What is that? Distance residency program. तो इतना distance मत करो तुम लोग आगे आओ because this is for you. Please come forward. What I will not speak much. I'll speak for about 5 minutes only, without any slides. आओ तुम लोग शर्माते क्यों? I simply do not understand. Please come forward. It will be an interactive thing. Or you want to talk didactic, तो मैं भाषण दूंगा वहां से. हाँ, इधर आओ, क्वेश्चन ही पूछेंगे हम. इधर आओ. Come. All PGs, please come forward. Run. Run and stand here. Come here. आओ. All PRCs, please come here. DRCs, whatever it is. DRPs, yes, come here. I will go to you. Okay. Have you ever used insulin? Yes or no?
Yes, sir. In the world.
What insulins do you know?
Sir, long acting,
नहीं, I want, ठीक है, long acting,
human insulin.
human insulin.
Yes, sir. Basal, regular insulin.
तो मैंने कोई सब्जेक्ट रो सब मेडिसिन huh? Pathology, yes, but you will be using it in your practice. Okay, when do you start using insulin?
Sir, I'm from pulmonary medicine.
ठीक है, फिर भी medicine. Okay, pulmonary medicine, but basically you're MBBS. बोलो.
Sir, uncontrolled diabetes in what ଯେତେବେଳେ ଆମର patient ବହୁତ ମାନେ OH control ହଉନି ତ inflammatory ଇଏକୁ
ज़्यादा टेक्निक नहीं. Uncontrolled diabetes. What do you mean by uncontrolled diabetes?
Sir, if the HbA1c is more than 10,
Okay, more than 10. Anyone would like to differ? Okay, तुम लोग बहुत lavish patients हो, बहुत ज़्यादा sugar करना चाहते हो, ठीक है. Whenever, बैठो, please sit. Now we start using insulin when we cannot control the blood sugar with tablets. Insulin was the first hypoglycemic agent discovered in the year 1922, 21, 22, 23. And after that, companies are at a competition to drive out insulin. Jayant? The only competition amongst companies is to insulin ko hatao yahan se. है ना? All the new things like sulfonylureas, gabapentlamides and DPP4 inhibitors, GLP-1 receptor agonists. So they are all insulin ko hatao. Yes, insulin ko hatao. But insulin hatne ke bajaye it's becoming more prominent. And why? Because more and more people are landing up in uncontrolled with oral hypoglycemic agents. And when will you start doing it? When will you start acting insulin? If he's a young person, as early as the HbA1c level crosses 7.2, 7.3, that is the time with 3-4 OHAs, start insulin. This is because the younger the patient, the more life he has. Okay? And which is the first insulin you will use?
mixed insulin.
Yes. Which is the first? ठीक है. She is telling mixed.
so if the patient is on indoor setting or if the patient is hospitalized,
Yes, it is the long-acting insulin. In fact, what we do is we have 3-4 OADs and the patient is not controlled. We start thinking insulin, yes, but which one do you add? You add a basal insulin. And we have varieties of basal insulin. There is an NPH insulin which has got a slight peak. It lasts for about 16 to 20 hours. We have better ones which are almost once a day, and we have still better ones which is almost peakless. So it's up to you to add. And when will you think of the next level of insulin? And what does it do to the insulin, to the glucose levels? The basal insulin, it brings down the whole curve of insulin. जो peaks है ना वो नीचे ले आता है. And then when will you add? When will you think of doing something more? When, in spite of adding maximal basal insulin, you still have an HbA1c more than what you have fixed. And then what do? You add a rapid acting insulin first at the time the patient has his most big meal. Usually it's lunch in India. Jayant? It's usually lunch in India. So we have a basal insulin. Usually it is given at about 8 o'clock, 9 o'clock in the evening. And then you add a short-acting insulin for lunch. Okay? And that is called a basal regimen, and then we have got a basal plus. If it's basal and one rapid acting, it's called a basal plus. Lekin once the patient starts deteriorating more, you have to give a basal insulin with 3 short-acting insulin. That becomes physiologically correct, and that is called a basal bolus regimen. So this is for all of you who are non-MDs, because MDs have this basic information. But for those who are practicing as MBBS and are wary of writing insulin, I think this information will go a long way for all of you. Thank you very much. Yes, Jayant would like to add, but Jayant, 2 minutes.
Just to add, the dose of basal insulin, sir ने बहुत अच्छा बताया. Dose of basal insulin is 0.1 units per kg body weight or 10 units. Remember, blunt 10 units can be a start dose or a 0.1 unit per kg body weight. Yeah, in addition to which, when you are shifting, and then you have to titrate +2, -2. If fasting is high, increase the basal unit by 2 units more. If fasting is low, decrease basal unit by 2 units less.
And there is a term called patient empowering. Whenever the patient comes to you, the patient need not come to you every week. You have to give your mobile number. You have to make your clinic digital, as Jayant has made. So the patient will talk to the patient, to the doctor or his or her agent about his blood level and how much he has to add or subtract. So maybe every 3-4 days he does a fasting sugar, because we have to first target the fasting sugar. And then the patient talks ki aji more etiki heichi. And then the doctor will tell, once he gets the free time, that you increase by 2 or decrease by 2 or increase by 4, decrease by 4, whatever it is. So that is called the patient empowerment. And one for all of us is that if you want to be really high tech, have a continuous glucose monitoring. That will give you the exact timings when the patient requires an insulin, because I did, like Jan did it, even I did a CGM in myself. I saw that if I didn't have proteins with my breakfast, the blood sugar used to rise. I added protein sprouts, it was normal. So it all depends, but you have to decide how much high tech you want to become. By the time you become practitioners, I think you all will become high tech. Thank you very much. If you have any questions, we are always there. All the professors are here to answer. In fact, all of us are armed to do it. Gopal can advise you, anyone. So it's nothing, but you have to start insulin. So don't have a treatment inertia कि मैं थोड़ा सा और देख लेता हूँ. पेशेंट बोलेगा सर इस बार छोड़ दीजिए, मैं वो पूरा करके आती हूँ नेक्स्ट टाइम. लेकिन दैट नेक्स्ट टाइम विल नेवर कम. यू हैव टू स्टार्ट, बट डोंट फाइट विद द पेशेंट. Once you start fighting with the patient will not come to you. You simply have to tell कि देखो तुम मर जाओगी जल्दी if you don't come into your normal limits. So but don't keep on, नहीं तुमको 90 को पड़ी वैसे आओ 80 को नहीं. So do it in a very I would say nice way, friendly way. Thank you very much. If you have any questions about that.
Just to add a point, from animal insulin, we have shifted to human insulin. Now from human insulin, we are shifting to insulin analogs. So in this basal segment, we have 2 insulins now. One is glargine and one is degludec. The detamir no longer is available. So glargine and degludec are 2 long-acting analogs available. And in ultra short-acting, we have lispro, we have aspart, and we have glulisine. They are having the advantage, they don't cause nocturnal hypoglycemia. There is a flexibility of dose. आधा घंटा 1 घंटा late हो जाए तो भी problem नहीं है. Patient tolerates very well, sense of well-being is very good. And this is something beyond nature. Nature has given the human structure. Animal is deficit, less than that. And now we are going beyond nature, the analogs, era of analog.
Thank you, Jayant. I would like the chairperson to invite the next speaker. And I would request him or her to be as short as possible, maybe complete it in 10 minutes so that we can have a valediction and so that the Bhubaneswar and Cuttack delegates can catch the train after the valediction. So maybe finish whatever you want to say in the next 5 minutes.
First, let me thank Dr. Ashok Singh and Dr. Professor Jayanta Panda because of panicless information regarding insulin. So this after that panicless information, let us invite Dr. Sarada Misra to give the most informative. Out of the, I think this is the best information if you get the cutaneous manifestation of endocrine disorder. Otherwise, there was a topic called the cutaneous manifestation of systemic disorders. So it will be really interesting topic. Let us hear from him. Thank you. And Dr. Sarda Misra needs no introduction. I think everybody knows. 5 minutes, more informative. Thank you.
Okay. Respected seniors and my juniors and colleagues, my topic is cutaneous manifestation of endocrine disorders. Next slide. Endocrine disorders represent a significant component of the global non-communicable disease burden, affecting individuals across all age groups and significantly impacting quality of life and healthcare system worldwide. Despite of advancement in medical technology, healthcare delivery, the global burden of endocrine continues to rise, and particularly in low and middle income countries where healthcare access remains limited. Hormones are critical regulator of several physiological processes in the human body and play an important role in each system. The deficiency or excess as seen in endocrine disorders can result in numerous cutaneous manifestations which range from mild to severe forms, may or may not be specific. Some cutaneous manifestation may be in early onset and can help in early diagnosis and treatment of the underlying endocrine disorder. Coming to classification of endocrine disorders, these are the classifications. Coming to disorder of hypothalamic pituitary axis, acromegaly, growth hormone excess generate an insidious cascade of clinical manifestation involving soft tissue and bone, cutaneous involvement mostly seen over face, hand and feet, facial thickening, edema mostly seen as coarsening of the chin, nose, supraorbital ridges as well as prognathism, macroglycia, microcelia and gingival hyperplasia. Pronounced nasolabial groove, increased size and redness and wrinkling of the forehead can produce a melancholic expression. Cutis vertis gyrata and small fibroma due to fibrous tissue overgrowth are also common facial features. Increased production of sebaceous and sweat glands manifest as oily skin and hyperhidrosis. Cutaneous manifestation of acromegaly include macroglycia, microcelia, gingival hyperplasia, coarse facial features, cutis vertis gyrata, hyperpigmentation, acanthosis nigricans, hyperhidrosis, hypertrichosis, and platinacea. This is a picture showing cutis vertis gyrata. This is a picture of platinacea, pronounced nasolabial groove, wrinkling of the forehead, macroglycia, and microcelia. Disorders of thyroid gland. Graves' disease, autoimmune thyroid disorder characterized by presence of autoantibodies to the thyrotropin receptor. Clinical manifestation of hyperthyroidism is seen. Excess thyroid hormone leads to increased body temperature and hyperhidrosis, manifest as soft, warm and moist skin. Loosening of the nail from the nail bed causing onycholysis. Peritibial myxedema, also called as thyroid dermopathy, presents as a flesh-colored, yellowish-brown raised skin lesion overlying a non-pitting thickening and induration. Common site of peritibial myxedema is anterior tibia, dorsum of the feet, toes, and sites of repeated trauma and surgical scars. Coming to Hashimoto thyroiditis, it is a chronic lymphocytic thyroiditis. Reduced production of thyroid hormone leads to cold and dry skin. The accumulation of mucopolysaccharide leads to classical presentation of myxedema. The pretibial area is the most commonly involved site. Macroglycia, broadening of the nose, thickening of the lips, erythematous skin eruption mimicking dermatomyositis. These are the cutaneous manifestation of hyperthyroidism. Warm, moist, smooth skin, flushing, palmar erythema, hyperhidrosis, diffuse scalp hair thinning, onycholysis, peritibial myxedema, thyroid acropathy, generalized pruritus, and chronic urticaria. Cutaneous manifestation of hypothyroidism include dry skin, cold mottled skin, carotenemia.
Thank you, madam. I will summarize very early.
Okay. This is the Coming to glucagonema, the triad include diabetes mellitus, skin lesion known as necrolytic migratory erythema. This is a picture of necrolytic migratory erythema. Diabetes mellitus, patient of diabetes mellitus has increased susceptibility to cutaneous infection like candidiasis, erythema and dermatophytic infections. Necroviasis lipidica diabeticorum. It is a common condition in diabetes mellitus. Coming to diabetic dermatopathy, it is the most common dermatologic marker of diabetes mellitus. Diabetic bulla, they are non-inflammatory blisters, usually on the non-trauma prone sites, seen mostly on dorsum of foot. Scleroderma adulterum, it is common in adult patients. Other conditions include acanthosis nigricans, acrocoden and vitiligo. In Cushing syndrome, moon phases and buffalo hump are seen. Purple stria, hyperpigmentation and acanthosis nigricans seen. In adrenal insufficiency, hyperpigmentation is mostly seen. Other disorders for androgen excess include PCOS. Here, hirsutism, acanthosis nigricans, acne vulgaris, androgenic alopecia, female pattern hairless sin. These are the hereditary endocrine syndromes. This is a picture of chronic telogen effluvium in patient of hypothyroidism. This is a picture of female pattern hairless, acanthosis nigricans, hirsutism in patient of PCOS. Coming to acquired ichthyosis, this is seen in hypothyroidism and diabetes mellitus. Chronic urticaria seen in hyperthyroidism and diabetes mellitus. Hyperpigmentation seen in Addison's disease, ectopic acetous syndrome and Cushing's disease. Acanthosis nigricans seen in acromegaly, hyperprolactemia, diabetes mellitus and Cushing syndrome. Vitiligo seen in hyperthyroidism and diabetes mellitus. Thank you. Then why did you give me this?
Finish it as fast as possible. Mementos leke aao. Come. Come. Don't delay the mementos. Get them. Come, all of you.
Hello.
ठीक ଅଛି ma. I would now invite Professor Dalai for the valediction. I would request all the senior physicians gathered here to please come on stage for felicitations. Sure. And Dr. Jayant, please come. Rabi, aajo. Asa, Rath. Please come.
Now,
ठीक.
now I would
Good.
like to invite all the faculties from Department of Medicine to the dais to receive the token of gratitude from our organizing secretary, Dr. Dinabandhu Sahu.
I would request Dr. Dalai to say a few words about today's function.
And nothing to tell like that. So as a chairman API, I feel rather obliged by Dinabandhu to have a conference at Bhavanipatna. And on this auspicious day of Mahalaya, that I wanted to visit this place, which had बहुत दिनर इच्छा थिला जे भवानीपाटना आसिया पई. तेणु बोधे एटा गोटे सुजोग थिला मो पई जे कथा होचे आसिकरी जॉइन करिया पई. आ तेणु मोर अंतर गभीर उत्तम प्रदेश मु अंतत समस्त धन्यवाद जनाऊँगी, स्पेशली अशोक, दीनबंधु. They have tried all their best to make this function success. आ याठो भलो सक्सेसफुल कॉन्फ्रेंस इन ए मिड टर्म सीएमई रे हे पार न थान. आमे जेते मिड टर्म सीएमई करिचु इन पेरीफेरी, we have on it Bhubaneswar, Kotak like that. किंतु पेरीफेरी रे गोटे सच अमाउंट ऑफ ये सीएमई करा जिवो आ एते भलो अटेंडेंस हबो, एते भलो खाइबा भी आ भलो अरेंजमेंट ये थिला हमर शरत. आमे दिस ऑडिटोरियम इज वन ऑफ द बेस्ट ऑडिटोरियम. It's a very cozy auditorium. Right. Even Kotak, the stage is less than this. This is a very sumptuous auditorium and all that. So rather Sharath is very fortunate to be posted as HOD at this place. So thank you very much all. Dinabandhu, sir, this Ashok, and we are all fortunate to have this conference and CME. Rather, has been done by the grace of this Manikeswari Lord Goddess. So I knew that all our success is due to her blessings. So this is my all I want to tell in this meeting.
I want to convey my gratitudes and thanks to Pantoset division of Sun Pharma who single-handedly managed the entire event. My special thanks to Rahul and the Ashwini and I think that your manager has left. Chalo, ठीक है रहो तमें फोटो नहीं हो आओ जग्गू तमें आसो Jaggulal Agarwal, Atanu, Balram, Sucheta, please come. You are all so seniors. Please come on stage. I think we would love to have a nice picture with all of you. Jagannath, please come. You are. Yes. No, chair, bas chair. Please come. So. Srishti, Saurav, the only nephrologist in this hall, please come. Vikramaditya Padi, the only. Kahan gaya? Vikram? Vikram is there? Vikram, आओ. तुम्हारे भरोसे हम लोग आए हैं यहाँ कुछ हो तुमको लाने का एक ये है कबीर भी तुमको जो लेके गए हैं ना वहाँ that was his in the back of mind कि अगर something happens तो you are there. Where is Dr. Purohit? Where is Dr. Purohit? Mitali, please come. And I would also like to request Mrs. Dinabandhu to please come, Asa, and Dinabandhu's son, who sang so nicely. Dinabandhu. ठीक है. So, Dinabandhu, first of all, your mimicry, and then we'll go.
Okay. Thank you, sir. Actually, we became late. Actually, that's why we have to cut short the last speaker's Dr. Sarada's talk. So I, with due apology, so I think she's not here in the auditorium anyway. So one or two items. When I stand in the auditorium on the stage, the student days are in my memory. The eyewitness, Dr. Dada Achanti Kwadagale, he is there. He has witnessed my whatever activities. After the Achanti, Dr. Sushant is there. So one dialogue खाली मु कहिबी गोटे dialogue जोटा कि हमें गोरिल्ला बोली गोटे प्ले रे करिथिलु. So volume के कंट्रोल करूची. एठी किछि नहीं केही भी नहंती कुआडे केही भी देखा जाऊ नहंती एठी खाली पानी गछ वृक्ष केही भी नहंती भोक पेटर भोक मनर भोक हे भोकर अंत नहीं मो चिरंजीवी महाकाल मोर मृत्यु नहीं धन्यवाद थैंक यू वेरी मच ओके मिमिक्री आपण राति 10टा बेलू देखिथिबे कुकुर माने थिबे आ गोटे चढ़ई शब्द कर दूसरी आप काउ मान को देखिथे इनफैक्ट काउटा कौन होती ना मुझे हस्टेल थी बेलू सबुदिन जोब्रा को चलिया जाऊँगी आसला बेलू हस्टेल देखिली से चाइनीज पैम से काउ मैंने था दे आर माय टीचर्स मो रूम में बस साइलेंटली आई हैव से ऑब्जर्व एंड मिमिक देयर वॉइस धन्यवाद सर. Thank you very much.
Thank you. Yeah.
ମୁଁ ଗୋଟେ ଛେଳି ଛୁଆର ଇଏଟେ କରୁଛି.
So finally, ଗୋଟେ ଛୋଟ ଛୁଆର mimicry I will end. धन्यवाद. Thank you.
Thank you. It was a pleasure to have all of you here at this remote location of Bhawanipatna. But whenever we call all of you, please come. Maybe in the next 3-4 years, we will have another function here through API. And thank you very much. I'm inviting all of you again to Berhampur on 14th, 15th, and 16th of November. Please be there. Thank you very much.
Sir, just a minute, sir. I would like to invite all the anchors and sisters. Please come. Please come to the stage and receive your mementos. Just 2 minutes, sir. Sir, please bring the mementos, small size mementos. चलो, नहीं चलो. चलो, धर इधर. अरे धर दो मेमेंटो धर. इधर धर. अरे 10टा धर. चलो, कम. 8टा धर के ऐसे.
So you did a very good job, all of you. Yes. Great. Yes. And in fact, they were the ones who received us. Very smart. गुटे अश्विनी को दिया जाओ. Ashwini and Rahul. Okay. This is for you, Ashwini. And I have told you about our future plans. We will do it at Phulbani very soon, maybe in the next session. Let's see. Ashwini has got a special picture. हाँ? लगता है. चलो. हाँ, ठीक है. From all the advanced team, this is for Sun Pharma. Please convey our personal thanks to your company.
So thank you, Sun Pharma, for being with us and helping us to conduct the midterm CME. Once again, sir, another surprise. Any of the medicine department, DRPs or any assistant professor, associate professor here, please come to the desk. There is a gift on behalf of the event to the whole of the medicine department. So if sir is there, okay, sir, please.
Sun has given us a check of, I think, deposit कर दिए? Sir, एमाने deposit कर चंती 292 and 294. We will give you 250 back. उसके लिए तुम लोग कंपनी को बोल देना. उसके लिए राजी हुए हैं सर. छोड़ दो. हाँ, we will give them back 250. We will keep 294 আসছে.
नहीं 294 আসছে. সেটা আমার রহিলা.
नहीं আমি तब we'll give you. We'll give you. We'll discuss.
That is one year to the cash. But we can hear that some 20,000 or like that we can give to the local CME people. They will have a celebration.
Actually, the title of the event was given by Mr. Ramlan. He is the third year MBBS student of BBM MCH. Sir, please come forward. And and please hand over a.
अच्छा आप पुटे मोर कुआडे वाला ये मो फोटोटा.
I saw the Dina bhai when I was in first year, he was in third year. I saw his son. Can you come here, please? Yes. So when I was just first year student and he was third year, So all during our undergraduate day, we used to cherish Dina Bhai's all art and painting. And when I listened this guy's, this boy's song, I was in tears today. God bless you.
So we are omitting the question and answer session because of lack of time. Maybe we may have a session like this in the coming years or maybe months. You never know. Sir, ame rohilu sir. Final thanks mu dei debi yanko. Kiye? Dakko.
Sir, Dr. Ponda, sir. Sir, please, sir, please. Hey, sir, please come.
Dr. Sadhu Charan Panda belongs to this place. I had a faint idea, but I was pleasantly surprised to see him in the morning today. He has just retired from the VSS Medical College, Burla. I think he's a year junior to me in college or batch, whatever it is. So it's a pleasure having you here. Sir, your impressions about this meeting?
Sir is the son of the soil, and always he's having some encouraging words to me and all the activities. So sir was the guest of honor during valediction. Sir, I request sir to tell few words.
In spite of all advancement in medical science, including starting from, say, wearable kidney to optogenetics, the only thing always required is touch, talk, and empathy. Unless we will have that, we can't have connectivity with patients, they can't have trust on us, and we can't render the best possible healthcare. Thank you.
Sir, I would like to request the token of love, Dr. Panda, sir. Thank you, sir. Thank you, sir, being with us. So once again, thank you all the delegates, all the esteemed speakers, chairpersons, those who have came all along, covering long distance and making the event a success. So I express heartfelt thanks to all of you. So now I declare the CME is closed. Thank you.